Welcome to Fertility Doc Talk. I'm your host, Dr. Kaajal Abrol. I'm a board-certified obstetrician-gynecologist and fertility physician based in Toronto, Canada. My goal is to educate patients, partners, and the public on fertility and to destigmatize infertility. Through this podcast, I aim to increase knowledge and awareness about reproductive health to empower people to make informed decisions about their own fertility. Welcome, everyone. Today's episode is on unexplained infertility, a surprisingly common and understandably frustrating diagnosis. Essentially, unexplained infertility is when a complete fertility workup has been done in an individual or couple trying to conceive, and no obvious cause has been found. Unexplained infertility is estimated to occur in somewhere between 10 and 30% of individuals and couples facing fertility challenges. First, let's remind ourselves what it means to be given a diagnosis of infertility. Infertility is traditionally defined as the inability to conceive after 12 months of regular unprotected intercourse in people in a heterosexual relationship. However, because of the significant impact of the age of the ovaries and eggs on fertility, it is recommended that individuals with ovaries who are under 35 years of age seek fertility testing and treatment after 12 months of trying to conceive. Yet individuals with ovaries who are over 35 years of age seek evaluation after 6 months of trying to conceive. Now, what does it mean exactly that you have had a complete workup and no cause has been found? Well, for the person with ovaries, the uterus and tubes have been assessed through an ultrasound test called a sonohystogram or an X-ray test called a hysterosalpingogram and found to be normal. Various hormones have been assessed, including thyroid hormone and prolactin, and also found to be normal. Ovulation has been confirmed, usually through a history consistent with regular menstrual cycles, and a thorough medical and gynecologic history has been reviewed and doesn't identify factors that could be playing a role. For example, endometriosis, which may be suspected based on symptoms or based on ultrasound findings. For the person with sperm, a semen analysis has been completed and also found to be normal. Once upon a time, laparoscopy to look for and diagnose endometriosis was done for most fertility patients as part of a standard workup. This is not routinely recommended or done nowadays because when you weigh the risks of surgery versus the benefits or improved pregnancy rates with fertility treatments in patients who are not symptomatic, surgery for diagnostic purposes does not show clear benefit. And a surgical diagnosis does not usually change the treatment path or plan. That said, it may sometimes be indicated, and this is something that can be discussed with your fertility specialist. Unexplained infertility can be a frustrating diagnosis, for patients for sure, but also for physicians, because we all want to find the cause for the fertility challenges. We all want to identify it and treat it. Personally, I don't think unexplained infertility means there is no underlying cause. I think it means that an obvious cause for the fertility challenges has not been identified through the tests we have and use to diagnose fertility issues. But there is likely something less obvious or harder to diagnose playing a role. Some possible causes I often think about are 1. Mild endometriosis. Perhaps there is some mild endometriosis playing a role, which is not symptomatic or evident on ultrasound, but still has an impact on fertility. 2. Poor egg quality. This is a big one, largely related to age of the eggs. Both egg quantity and egg quality decrease with age, and age is the biggest predictor of egg quality. 3. Poor sperm quality. Perhaps not obvious on a semen analysis, which may be normal. There may be a fertilization issue, whereby the sperm does not interact properly with the egg and lead to fertilization. 4. Implantation issues. Another one that is hard to identify, as there is no reliable, standard test to diagnose this. And 5. Lifestyle factors. This includes all the common toxins, such as smoking, excessive alcohol, and recreational drugs, but also the less obvious ones, which may play a more subtle role, like chemicals and plastics, and a diet high in processed foods. Egg quality is a hard one to figure out. I am often asked about a test for egg quality, but there is no test for this. The best test we have right now for egg quality is when the eggs are taken out of the body during IVF, fertilized with sperm in the lab, and then the embryos are grown in the lab. This embryo development may give clues about potential egg quality issues. Egg quality decreases with age. This is well known, but sometimes egg quality is also shown to be a factor in younger people with ovaries and eggs, and it's important to be aware of this. It's not always known why, but it is sometimes seen. Now that we have discussed the meaning of unexplained infertility and some potential factors that might be playing a role, let's move on to understanding pregnancy rates and treatment options with unexplained infertility. By the time an individual has been trying to conceive for 12 months and then sees a fertility specialist, has a complete workup, and is then diagnosed with unexplained infertility, their chance of pregnancy per month on their own is less than 5%. So what are the treatment options for unexplained infertility to improve pregnancy rates? Treatment for unexplained infertility is largely empirical, since a treatable cause has not been identified. A common starting point for unexplained infertility is controlled ovarian stimulation using oral medications or tablets like clomiphene citrate or letrozole, and combining this with intrauterine insemination or IUI. Controlled ovarian stimulation and IUI improves pregnancy rates by increasing the number of mature eggs that ovulate in a cycle, ideally to 2 to 4, while also increasing the number of motile sperm in the uterus at the time of that ovulation. Medications in this treatment are started early in the menstrual cycle, usually starting on day 3 or 4. The oral medications are taken for 5 days. The cycle is monitored with serial blood work and ultrasound every few days to look at ovarian follicle growth, blood hormone levels, and uterine lining. This is referred to as cycle monitoring. As a few follicles grow and the eggs inside of them mature, the estrogen level in the blood should rise and the uterine lining should thicken on ultrasound. Ovulation may occur on its own, or it may be triggered with an injectable medication, which is an HCG or human chorionic gonadotropin injection. HCG is similar in structure to LH, or luteinizing hormone, the hormone in the body that triggers ovulation. So an HCG injection can be used to help trigger ovulation in a fertility treatment cycle. Intrauterine insemination, or IUI, is where a sample of sperm is washed and processed to remove any debris and concentrate the good motile sperm. The good quality sperm are then placed in the uterus so that they are one step closer to the eggs, compared to intercourse, where the sperm is ejaculated in the vagina and must make its way through the cervix and the rest of the uterus and then into one of the fallopian tubes. With IUI, the sperm must still make their way from the body of the uterus into one of the fallopian tubes, but they are closer. Other milder variations of controlled ovarian stimulation and IUI include controlled ovarian stimulation and timed intercourse, or a natural cycle and IUI. Both of these have not been shown to increase pregnancy rates significantly and would not be recommended in most cases of unexplained infertility. Sometimes injectable fertility medications are used for controlled ovarian stimulation and IUI. However, this is not always an ideal step, given the high risk of multiple pregnancies with these medications, meaning twins, triplets, or even more, and an increased risk of cycle cancellation for over-response. So this treatment option really must be individualized to the patient. If controlled ovarian stimulation and IUI do not work, then it is commonly recommended to move on to in vitro fertilization, or IVF, which usually gives the highest pregnancy rates. Depending on your individual situation and family planning goals, sometimes IVF is considered right away, without pursuing controlled ovarian stimulation and IUI. IVF is a process in which the ovaries are stimulated to produce a number of mature eggs. The eggs are taken out of the body and fertilized with sperm in a lab to create embryos. And then the embryos can be transferred into the uterus, usually one at a time, to hopefully implant and develop into a pregnancy. Similar to controlled ovarian stimulation, cycle monitoring is used in IVF to monitor the response to the stimulation medications and the timing of the egg retrieval procedure. In general, for unexplained infertility, treatment recommendations should take into account the patient's age, the duration of infertility, and the desired family size. So there you have it, all about unexplained infertility. What this diagnosis means, what is potentially going on in some of these cases, and what the treatment options are once a diagnosis of unexplained infertility is made. I hope this episode was useful in allowing you to better understand unexplained infertility and how fertility treatments can be used to improve pregnancy rates. This is the last episode of Season 1 of Fertility Doc Talk. I've been asked a lot about why I decided to do this. Why start a podcast? In over a decade of practice, I have come to realize how much basic reproductive health information is just not known. And through social media and my patients, I've come to realize how much misinformation is out there. So I wanted to start this podcast to educate, to give patients and the public credible fertility information. But I wanted this podcast to be more than just fertility education. I also wanted it to be a platform where we would share stories and experiences. Because by bringing these conversations to the forefront, we are supporting those with fertility challenges and breaking the stigma around infertility. To that end, Season 2 is coming up soon. Get yourselves ready for so much more fertility information as I sit down with various experts. We will talk about medical and non-medical fertility topics, up-and-coming treatments, and so much more. And if you are enjoying the podcast and excited to see what's in store for Season 2 and beyond, please make sure you follow, rate, and review the show. Your support is crucial to help the podcast grow and to allow me to reach more listeners. That's it for this episode of Fertility Doc Talk. I really hope you enjoyed listening and learning and feel empowered about your reproductive health.